In this lecture, we're going to be talking about anxiety and depression. Two very common emotions, challenges when it comes to crisis and trauma. Our professor for this course is Dr. Archibald Hart. One of my favorites. You're going to love him. He's got that old English draw to him, but he's a man with a great wealth of knowledge. He is Senior Professor of Psychology and Dean Emeritus at Fuller Theological Seminary School of Psychology. Arch has written more than 26 books, has a wonderful, gracious family. He's a delightful man who loves the Word of God, and he's a brilliant man when it comes to understanding anxiety and depression.
I agree. He's a dear man, and he's going to first give us some definitional terms, Tim, of anxiety and depression, and help us understand about neurobiology, help us understand these terms endogenous and exogenous and all these things. That's right. But they're important to understand what we're talking about. And then additionally, he'll talk about risk signs, and these risk signs are useful both as we look at lifestyle interventions and as we look at pastoral and ministerial interventions into the world of anxiety and depression. So we have a great treat ahead of us. He'll also weave biblical applications through this process. And so now we give you Dr. Archibald Hart.
Welcome to this video. I'm so happy to be here with you and to share with you in this very, very important topic of how stress, post-traumatic stress disorder can create depression and anxiety problems as well. This is an extremely important topic and growing in importance, primarily because the United States has been at war for some years now in several parts of the world, and we are seeing firsthand a dramatic increase in the number of our troops and their families experiencing post-traumatic stress disorder. Now, my focus in this particular video is not so much on post-traumatic stress disorder per se, but on how post-traumatic stress disorder creates both depression and anxiety-related problems. How they relate has been studied very, very carefully. It appears that in the early stages of post-traumatic stress disorder, in the acute stage, the depression and anxiety problems seem to be somewhat separated. But as the disorder continues, as the weeks and months roll by, depression and anxiety seems to separate from the post-traumatic stress disorder and becomes conditions in their own right that are comorbid with the stress disorder. And this is an important point for us to keep in mind as we look at the trauma-based forms of depression and anxiety. Because the emergence of depression and anxiety problems exacerbates the seriousness of the post-traumatic stress disorder. Now, it is clear that trauma can occur in many life situations. Anything in life that is dangerous can cause it. And while war or combat stress is right now on our minds, and rightly so, we are concerned about it, there are many other forms of trauma that can cause this disorder as well. So let me briefly just mention some of them. Assault can be a very common cause of post-traumatic stress disorder. Serious car accidents can cause it. In fact, in our own family, my oldest daughter about a year ago had a very serious car accident. And it's the stuff of which serious stress disorders are created. Other accidents or injury, fire, floods, earthquakes. I come from California, and we've just been through a whole series of fires and floods. Thank God we've not had any earthquakes recently, but it's just a matter of time and we will be facing that sort of trauma as well. Threatening life illness, sudden death of a friend or a family member. Again, just to personalize it for a moment, we had a tragic death of my son-in-law in the prime of his life, in his mid-30s, 10 years ago, and that was very, very traumatic. And of course, finally, it is the combat stress that can be so terrible in its effects on our young people in particular. And almost everyone today knows of or is closely associated with or connected with people who are suffering from war-induced trauma and the consequent depression and anxiety that goes along with it. Which is why this series of videos is so important in my opinion. We have to educate families and people, and particularly churches, to be much more effective in the way they respond to and help those who suffer from post-traumatic stress disorder. So my focus here is on how post-traumatic stress disorder induces or creates depression and anxiety problems. The effect is not only on the person suffering the trauma. The trauma has a far-reaching effect. It's like a ripple effect. It starts with the primary person who is traumatized, and anyone closely connected to that person is also traumatized, and it spreads all the way through, carries all the way back to families and to children. So it has a very wide-reaching effect, and we call that vicarious stress because it can be so widespread. Now, what are the risks of developing depression and anxiety problems following PTSD? Firstly, let me differentiate between stress and trauma stress. Every one of us goes through a little stress in our lives. I'm here presenting this video, and I'm a little bit stressed because, you know, it's anxiety producing. And so there is stress in all our lives. But traumatic stress is a totally different form of stress. And as we will see in a little while, its effects on our body, on our mind, is much more powerful, much more serious than the ordinary stress that we experience day by day. Someone who suffers from PTSD will experience double the risk for major depression. That's the most serious form of depression. And also anxiety disorders. It'll double their risk of those disorders. And if you experience PTSD, there is a tripling effect on abuse, substance abuse, addictions. But not only does PTSD increase the risk of depression and anxiety disorders, but if you have some pre-existing depression or anxiety disorders, and in this high-stress world of ours, there's a high percentage of people who already are highly stressed before they experience the traumatic stress. But if you have some pre-existing, say, depression, it will increase the vulnerability of the trauma. Also, if you have adverse childhood experiences, that will increase the impact of the PTSD. And my point being here that these effects are sort of interactive. If you have depression and anxiety before you experience the trauma will be worse. If you have a serious trauma and then develop depression and anxiety problems, then the depression and anxiety problems are going to make the trauma worse. So altogether, it's important that we consider carefully the depression and anxiety components. And whatever help we bring to those who are suffering from PTSD, whether we are counselors or professionals or clergy or chaplains, or if we're just people in our churches who want to help in some way to the people who are experiencing post-traumatic stress disorder, to bring their lives back together again into a harmonious whole, then it's important that we understand this interaction effect between PTSD and depression and anxiety. But let me now just say a few words about the meanings of these terms. What are some of the definitions? When we talk about anxiety, what sorts of anxiety problems emerge out of post-traumatic stress disorder? Well, it can be almost the whole range of anxiety disorders. PTSD can, because of what creates the PTSD, also creates the anxiety disorders. We can see, for example, panic attacks can develop. Agoraphobia, which is a fear of the marketplace where you're trapped, you don't want to leave your home because you're afraid you're going to have a panic attack. Certain phobias. Phobias are very, very common in PTSD. As we will see from the mechanism that creates PTSD, it makes the fear of the trauma, turns it into a phobic type of fear. You can also get obsessive compulsive disorder, and then a generalized anxiety disorder as well. So those are some of the examples of anxiety disorders that can be triggered by PTSD. Depression comes in various forms also. Major depression, episodes of depression, unstable mood disorder can arise, and possibly even mania or bipolar disorder. Manic episodes can occur in predisposed individuals. And lastly, let's not forget that trauma can create very severe form of separation anxiety. A person who has been traumatized, for example, my young grandson, who at only 10 years of age, his daddy was killed in a car accident, went through a period of intense separation anxiety. His fear was that his mother would also die in an accident, and so he didn't want to be separated from her. And for quite a while we had a struggle to get him to go to school, for example, because he wanted to be with his mother all the time. He felt that if he was with his mother, then his mother was safe. And these are the sorts of anxiety disorders that can seriously affect the lives of those who are traumatized. It's also important that we differentiate between two types of depression and two types of anxiety. The one type of depression is called an endogenous anxiety. Endogenous, endo meaning within, comes from within. And similarly, there are endogenous forms of anxiety. In both the depressions and anxieties that are endogenous or from within, they are biological primarily. They are biochemical, essentially. In other words, there's been some disruption to the brain mechanisms, the neurons, the pathways in the brain that are creating the depression and the anxiety. And in a moment we'll see how that happens and why it is so closely linked to post-traumatic stress disorder. But the other form of depression and anxiety is called exogenous. That means from without. It is also called reactive. It is the anxiety or depression that occurs in reaction to something that's going on in your life. Usually it is something like the loss, like a young combat soldier who loses a limb, say an arm or a leg, during some explosion. That traumatic injury is one major issue that will be dealt with. But But bear in mind that there's also a significant loss here, so that one can experience both depression and anxiety as more psychological in response to the traumatic event. So the point here is that it's important that we understand that there's endogenous depression and anxiety. There is exogenous or reactive or psychological forms of depression and anxiety. And any treatment, any follow-up, any support, whatever we do to help a person with such a disorder has to take into account both the biological depression and the psychological depression. And a little later, when I get to the intervention strategies, we'll discuss how we treat these two forms of depression and anxiety differently. Let's now have a look at what causes the depression through the trauma. What is it about the trauma that puts one at risk for depression and anxiety? We need to understand this in order to make sense of whatever strategies we use, however we minister. I think even a pastor in a pulpit preaching to combat veterans, for example, who are traumatized, suffering from PTSD, needs to understand these mechanisms to facilitate the healing process. It is a complex problem. PTSD and its interaction with depression and anxiety is a fairly complex one. It's not a straightforward separate disorders. They are very, very commingled. So in trying to understand how depression and anxiety will arise from a traumatic event, let's look first of all at the brain itself, the neurobiology of the mood disorders. We know a lot now, a lot more than we did, say, 10 years ago, about how trauma can not only create the fear and the anxiety, the stress disorder that we call PTSD, but also how it creates the depression and the anxiety problems as well. You will see a graphic shortly on the video that shows the brain and a part of the brain called the trauma triangle. So to understand PTSD and how it creates depression and anxiety, we need to look at this triangle, a trauma triangle. It has 3 parts, 3 components. And each one of these components is affected by severe trauma. The first part is called the prefrontal cortex. Now that's a long label, but it's simply the front part of the brain. The part that you could grab if you grab the top of your forehead here and hold it. In this very part of the brain here is the prefrontal cortex. This is the thinking part of the brain. This is the part of the brain that orchestrates our thoughts and our actions and takes control whenever there is some sort of threatening event. So, we see a fire starting in the corner of the room. I nearly set my kitchen on fire once, many years, a long time ago now, but I'll never forget the experience of walking into the kitchen and seeing those flames, Now, the prefrontal cortex gets the message, first of all, from the eyes and the smell and everything else. There's a fire here. It tries to reason and to think and strategize and figure out, well, what you're going to do. And it's a wonderful part of the brain, but it's a little slow when there is an emergency or a traumatic event. So there's a second part of the brain in that triangle called the amygdala. Now, it's a very small part of the brain, just a little organ, but it has a very unique function in that it stores the memory of traumatic events, of fearful events. So, from the day you were born, maybe you dropped the thing you suck in your mouth, a traumatic event. The amygdala remembers that. That time in early childhood when you put your hand on a hot plate, electric plate, and burnt your finger, that gets remembered by the amygdala. So the amygdala has a very important function in that it is a memory part of the brain, but primarily for fear, so that when there is an emergency, you haven't got to wait for the thinking part of your brain to do anything. It responds immediately. It screams loud and clear, danger, danger. That's the amygdala. That's the second part of that triangle. So what happens then in a traumatic event is that, that this part of the brain, the amygdala, stores the memory of that event. Then there's a third part of the triangle, the trauma triangle, is called the hippocampus. The hippocampus is like a horseshoe-shaped part of the brain right down in the middle, wraps right around both the hemispheres. It has an important function as well. And in traumatic experiences where post-traumatic stress disorder emerges, this part of the brain, this hippocampus, shrinks. It atrophies. As much as 28%, it shrinks. And that is the third part of this trauma triangle that has serious consequences, in that this part of the brain has a very, very important function. It creates new brain cells. It's something called neurogenesis. Brain cells, genesis, new beginnings. And so this part of the brain, every day, more than 1 million new brain cells it creates. So if it shrinks, it's not producing enough new brain cells. Now, what effect does that have on the traumatic event? It means, therefore, that the prefrontal cortex, the first part, isn't in control in a traumatic experience. A young soldier having a serious explosion or seeing his buddy being shot to death. The brain hasn't got time to think about and process that and to organize and plan a strategy. Immediately the amygdala kicks in and the hippocampus is shrinking, not creating, not providing the brain with new brain cells. And this affects the memory very, very seriously. This is why we see in post-traumatic stress disorder a traumatic memory, a memory that will not give up, will not forget, vividly rehearsing it and presenting it to us. So these three parts of the brain are very, very critical in the development of post-traumatic stress disorder, and in a moment we'll see that it goes one step further in that it now also creates the depression and anxiety problems that we have to contend with. So what is it then that links PTSD to depression and anxiety? Well, the trauma triangle that you saw a little while ago is being affected by the trauma in that an important hormone called cortisol, which is one of the stress hormones released by the adrenal glands, your adrenaline system. Most people know about the adrenal system and the fight or flight response. Well, in severe trauma, this part of the body, the adrenal gland, releases this cortisol. And it is primarily the surge of cortisol that creates the effects in the trauma triangle that then leads to depression and anxiety. And it does it in this way. Initially, the cortisol that is released in a moment of urgency or crisis or trauma, initially, and I say probably in the first 2 weeks, this cortisol is helping us cope with the emergency. It helps us fight better, flee better. It helps us cope better with the emergency that is before us. And in normal stress, that crisis would pass away and and everything would return to normal. But with traumatic stress, the remembrance of a frightening experience, such as would come in a traumatic experience, doesn't let go. It stimulates, it keeps that system going, keeps the cortisol going. And when that cortisol is now in prolonged surge, it changes its strategy. It's wonderful. I just marvel at how God has designed our bodies. Because whereas the cortisol initially is designed to cope with the emergency, at a certain point it realizes you cannot deal with that emergency. It's beyond you. And it then switches its function. It's in order to help you survive. In the first part, it's to help you feel better. But at a certain point, it's no longer interested in you feeling better or feeling good. Your body's sole function is to preserve your life. And at that point, cortisol changes its strategy and it starts to do something quite differently. And what it does now is that it goes to certain parts of the brain that have to do with tranquility, our peacefulness, and cortisol also disrupts the neurotransmitters in the brain that are responsible for keeping us out of depression. And the neurobiology now takes over, and the chemistry of the brain begins to be altered by this tremendous surge of cortisol. It's the cortisol that causes the hippocampus to shrink and now creates a memory system that cannot restore itself well. So you keep getting these flashbacks, you keep getting these terrible images coming at you. And it also begins to shut down an important part of the brain responsible for our tranquility. There is a very, very powerful hormone called GABA, which is the sort of CEO for peacefulness. It's the GABA that keeps us at peace, and cortisol blocks it. And it's intentional, it's purposeful in all of us, because at the point of preserving your life, you're not going to get out of that terrible situation if you're feeling peaceful. And so it's almost as if nature creates in you a lack of anxiety in addition to the fear, so that you will take steps to get out of the situation. There's another graphic that will be on the screen in a moment that shows the progression now on a chart. So if you'll just look at that for a moment with me, we can now see what happens when a traumatic event occurs. So it starts on the left-hand side. And as the trauma occurs, we see the rise, cortisol goes up. And for the first 2 weeks or so, the cortisol is working to our benefit, helping us cope. But then it changes its strategy. And by the 4th week, cortisol now is shutting down these various systems. And that's why at the 4th week of a traumatic experience, only that we diagnose PTSD. Now at that point, that critical point, in fact the first 4 weeks is critical, and when I get to discussing some of the interventions, I'll say a little bit more about that. But by the 4th week, we have to have intervened in some way to redirect the course of the trauma outcome. And as you'll see on the chart, it can go up as post-traumatic stress disorder, or we can turn it around and move it down into post-traumatic growth. Now I know that there will be a video later in the series discussing post-traumatic growth, but the point I want to make here is that the difference begins at about the 4th week, which does not give us a lot of time to intervene, which is why we need to know and why we need to be mobilized. That's why we need to have the help necessary for us to be able to take that point in the experience of PTSD and begin to redirect it in the direction of post-traumatic growth. Just a few statistics before I get into to talk about the intervention strategies. Major depression and PTSD will occur together initially in about 30%. In about 30% of cases. That's by the 1 month. That 4-week period when it's now becoming diagnosable as a post-traumatic stress disorder, there is going to be depression, serious depression, in about 30%. Now, when you look at the 4-month period, when you look a little bit further on, that 30% becomes 45%. 45%. And that means that the crisis isn't over at the 4th week. It means that the seriousness of the disorder is continuing to grow. And the longer you leave it, the more likely it will become a chronic disorder if you're not able to turn it around and move it in a healthier direction. All right, now I would like to turn your attention to some of the general intervention and some of the prevention strategies that we are able to invoke. We know a lot about PTSD. We know a lot about its treatment. And many of the psychological treatments and some of the biological treatments that have been developed will be explored in more detail in videos to come. What I would like to do here is just to give you a broad or a brief overview of how the depression and anxiety components of PTSD can be addressed. In other words, how can the intervention in PTSD also include attention to the depression and anxiety disorders? I mention this because it is very easy to overlook the presence of depression and anxiety disorders when you have a serious PTSD. The traumatic event seems to overshadow the others, but we really have to be looking at the whole here. Who is at risk for developing serious depression and anxiety problems following a traumatic experience? Who is at risk? Some statistics here are very helpful, and this has been studied carefully so that we can know ahead of time who should be getting particular attention and their depression and anxiety being addressed, as well as whatever else is going on in the treatment. Those at risk for developing trauma-based depression include, first of all, those who have some pre-existing morbidity. Any disorder that someone had before experiencing the trauma is going to be exacerbated by the trauma. So if you have, say, a bipolar disorder where you are both depressed and manic, and you experience PTSD, you will have PTSD with a much more serious bipolar disorder accompanying it. That's true of anxiety disorders. If you are prone to panic anxiety before your trauma, the trauma is going to bring out that. In other words, the trauma is going to increase that surge of cortisol that is responsible for depression and anxiety and make both those conditions worse than they were before. So it's a pity we couldn't pay a little more attention to, say, the genetics of those who are being put at risk for PTSD. If we paid a little more attention to that factor, we might be able to eliminate some of the more serious PTSDs that do occur. For example, someone who has a genetic history of schizophrenia, for example, or a family history of schizophrenia, should probably not be put in harm's way because we just know that it's going to make that disorder worse. Secondly, those who are at risk for trauma-based depression are those who lack social and environmental support. It just amazes me. The older I get, the more I marvel at the power of love, the power of companionship, the power of friendship, the power of social support. It is quite remarkable how powerfully the body is able to heal itself. We know, for example, that someone in a loving relationship has like a 500% boost in the immune system. And when you lack social support, when you lack the environmental support, the risk of developing serious depression and anxiety following PTSD increases dramatically. A third risk factor that needs to be kept in mind is the prolongation of the traumatic stress. We know that in combat soldiers, the redeployment itself can increase the risk of PTSD, and if some PTSD has already begun, it's going to exacerbate it dramatically. The constantly having to go back to experience the same fears, the same, your amygdala is already programmed with significant danger signals, and now to have to go back and re-experience that is just going to make it doubly worse. So any prolongation of the traumatic stress is going to create a higher surge of cortisol. It's all about this cortisol factor. And intervention strategies have to focus on minimizing the cortisol factor as much as you possibly can. Lack of coping skills. I happen to know of a young man who went to Iraq, and as a teenager, his coping skills were extremely poor. He couldn't cope well with his teenage life, let alone combat life. And of course, it wasn't a surprise at all that within the year he was returned with a pretty serious case of PTSD. So if a lack of coping increases the risk. And then certain personality traits also increase the risk. People who are antisocial, borderline personalities, people who are extremely angry, people who are already under high stress in their ordinary lives are not going to do well when it comes to the traumatic stress that they have to face. One very, very important stress or risk factor that I should mention is the risk of suicide. This is so critical, and I know there's a video presentation to come in the series on this, but since this is a depression discussion I'm having here, suicide is linked very closely to depression. Let me make a few comments about it. The risk of suicide increases dramatically in PTSD. Our combat soldiers, they see the suicide rate is now the highest it has ever been. Just this last year, there's a 20% increase in suicide rates. Someone was sharing with me just a few minutes ago, before starting this video, that there's something like 2 or 3 suicides a day, or attempted suicides a day, in our combat troops with PTSD. Suicide is often seen by the person who is suffering as a coping mechanism. It's the only way I can cope with this. The only way I can deal with this. Yeah, I have these memories flooding back. I can't get rid of them. I can't push them to the side. I have this constant surge of cortisol making me feel fearful. Well, the only way I can cope with it is perhaps to take my life. And so it is often seen as the only way out. And therefore has to be, we have to be on guard, have to be alert, need to identify as early as possible those who will be at risk for suicide. So what are some of the risk factors? Well, we know that being male is a higher risk. If you use alcohol, the risk is higher. If you have been abused, the risk is higher. If you have a family history of suicide, the risk goes up. Poor social environment, this is back to the support issue again. Those who don't have support, the loners, those coming back from war, or those experiencing a car accident or a traumatic shooting, gang shooting or something like that, who don't have good social support, are those who are going to suffer. A history of attempting suicide increases your risk, and then of course a family history of suicide. If you have a family, if someone else in your family has done it, it seems to make it a little bit more tolerable for you to consider it. In combat trauma, suicide risk is seen in multiple woundings, in extreme guilt reactions. Soldiers who feel guilty because their buddy was killed and they weren't, or maybe they took a buddy's place and the buddy went somewhere else and the buddy was killed. Anything like that, that creates a sense of guilt can do it. A loss of a buddy, a loss of a close friend can have a powerful impact on suicide risk. And then a sense of hopelessness, the sense of hopelessness. And this is why we in the church, those who are chaplains and so on, can have such a powerful influence, because the gospel is a gospel of hope. It can give you the healing mechanisms that you need to be able to get over it. There are some environmental factors that we need to think about or to consider. Gender makes a difference. Men and women do not experience trauma the same way, and they certainly do not cope with it the same way. And as a general intervention strategy, we really need to go with our gender strengths. Men, for example, don't know how to use social support. Men don't want to talk about feelings. Men tend to mask their depression. They go and hide it away. They go fishing. They go to work. They become angry and irritable. And in a host of other ways, men have ways of masking or dealing with their depression, and the strategies must be geared to those characteristics. Women, on the other hand, tend to use social support. They are more feeling oriented. They respond more to emotion-focused type therapies. Men respond to strategizing, have a plan of action. I often have patients say to me, "Man, just give me a plan of action. I know I've got this terrible depression, but just lay out a plan of action for me. Tell me step 1, step 2, step 3, and I'll follow those steps 1, 2, 3, 4. You can do that with men. You can't always do that with women. So we need to go with the strengths of our gender in order to provide the right sort of support for these people. Now, briefly, a few comments about clinical interventions. As again, there are more detailed information will be coming in future videos, but there are a few points I would like to make about clinical interventions, particularly as it relates to the depression and anxiety component. Generally speaking, the clinical intervention has to do first thing first. That is to reduce the cortisol stress response. That is the number one step in the intervening process. That, more recently, is being effectively done by the use of a very, very helpful drug or medication called Inderol or propranolol. This is a medication that's been used for a long time to treat high blood pressure. It's a beta blocker. What it does is it blocks the adrenaline system. It blocks these beta receptors. The message goes back to the adrenal gland, shut down the adrenaline, shut down the cortisol. And research is very, very clear that we can calm that system quickly. If we can calm that system quickly, we can reduce the risk of not only PTSD, but also the risk of depression and anxiety. And recently that has become a fairly standard protocol for early intervention. The long-term clinical intervention does involve using some antidepressants if there is depression. The SSRIs, or selective serotonin reuptake inhibitors as they are called, are very, very effective in reducing cortisol's impact on the brain. The hippocampus I mentioned to you that atrophies, you get about up to a 28% shrinkage. With SSRIs over a short period of time, that part of the brain can be fully restored. And once you restore the hippocampus, you restore the brain's ability to forget. Yes, forgetting is the brain's main function. It's its primary function. And by restoring that organ, the brain can do its forgetting in a healthy way and get that terrible, dreadful memory off the agenda. You will also later be hearing about some of the psychotherapeutic strategies that are used. And the one most commonly researched is, of course, the cognitive behavioral therapy. I happen to be a cognitive behavioral therapist myself, but I don't want to tout my own bias too much. There are a whole host of other psychotherapeutic and counseling strategies that can be helpful in the early stages of PTSD and also in the later stages. And remember, the later stages, the support and the treatment is just as important as it is in the earlier stage. There are some lifestyle interventions that need to be considered. One of the important lifestyle interventions that I would like to mention is that of relaxation and meditation. I've had a relaxation and CD and meditation, Christian meditation CD out for many years now, and I get many, many requests for it. But I was pleased to see a recent study out of in England, where they did a 10-year meta-analysis on the effect of relaxation and meditation, in my case Christian meditation, on depression and anxiety and stress, and their findings were outstanding. They found that it was significantly efficacious. In fact, over the long term, it is even more efficacious than some of the most powerful medications we've got. So God has, in a sense, given us internally some mechanisms that we can use. Interventions should also include the families of those who experience trauma. They get overlooked so easily. The spouses, the parents, the children. And there needs to be a targeted effort to help parents and their families and the children deal with the effects of trauma. Sometimes the children themselves have suffered the trauma. We see this in our big cities with all the gang warfare. A brother or sister is murdered. It has a very traumatic effect on the rest of the family. And it should begin right at the event. I mean, the intervention should be there as soon as possible after the event occurs. We used to have a program in our school where we trained students to go to elderly who had been burglarized, because that can be very traumatic for them. And within the hour was our rule in order to start. We have to educate teachers. We had a bad experience with my grandson I mentioned earlier, who, when his father was killed in an accident, he became so clingy to his mother, wouldn't leave her. He experienced tremendous separation anxiety. And when the time came for him, we had to get him back into school. Every half an hour he would go to the teacher and says, "I want to talk to my mommy, I want to see my mommy." And the teacher was totally insensitive, and we had to intervene and educate the teacher. There was a telephone in the classroom. We were able to arrange for my daughter, Alan's mother, to call every hour for the first few days, just to reassure him, and for the teacher to allow her to do that. Because for a 10-year-old boy, that reassurance can make all the difference between his experience being a traumatic one or turning it to a growth one as well. Parents can help their children by building buffers in their children. And the new positive psychology movement that is so very, very vital, revitalizing psychology right now, puts strong emphasis on the importance of buffers. When you teach a child character, you're giving that child a buffer. When you teach that child courage, you're giving it a buffer. And there's a long list of these buffers now that are getting a high priority in the therapeutic world because they can be powerful. And parents can, of course, pass that on to their children. Lastly, let me make a few comments about biblical-based interventions. The gospel is relevant. The gospel is relevant. Trauma is nothing new to this world of ours. The Apostle Paul talks about his experiences. In fact, I often make the remark that in New Testament times, the only stress there was really was a traumatic stress. Robbed. Paul described how he was being flogged, put into prison, brought near to death. Almost every thing he describes fits into the category of what we today would call traumatic stress. But the gospel is all about turning tragedy into triumph. And we can, I think, in a very significant way, contribute to turning tragedy into triumph, into turning post-traumatic stress disorder into post-traumatic growth. There are many strategies that will be covered in the video series to come, but let me say with all my heart, I believe it can be transmuted. I believe that we in the Christian world, we in the church, can provide our sons and daughters, our husbands and wives, with the tools that they need to take that tragedy and turn it into something triumphant. We've done it in our family's life. I've done it personally, and I know that we can do it. The church can help. The church needs to be open to training in trauma. We need to inform people in the church so that they're not insensitive when someone else has experienced a traumatic event. We need to give training in how to understand anxiety and depression, how to encourage other Christians to seek the right sort of treatment. There is such a strong anti-bias to, for example, the antidepressants, which is not justified. And ignorance is Satan's greatest weapon. And we need to bring understanding and knowledge and insight to the church, down all the way down from the pastor to the janitor. Everyone needs to have had some understanding of what it means to experience a traumatic event, and that there is hope, and one can transmute it. That is what the gospel is about. If I didn't believe that, I would not waste my time to come and even do this video. So God bless you as you seek to minister to those who suffer from serious trauma. I know that it matches the heart of God whenever we reach out in understanding and love and help to those who suffer. God bless you.